Susan, I'm just checking my audio. Can you hear
I can hear
me
you.
okay?
Yeah.
Okay. Okay, great. Thanks. 425.
Maybe your audio isn't great,
Connectivity
Owen. Like, can others hear him okay?
criteria.
Yeah, we can't hear you very well, Owen.
I hear the audio cutting in and out for the chair.
Thanks, Tim.
I apologize. Let me turn off my video. Susan, there?
Yeah, your audio is not good.
All right, Susan, I'm back. I'm gonna leave my video off. Is that working better?
That sounds better.
All right, I apologize about that. I think I'm having some internet issues today. I'll call to order the Green Mountain Care Board's hearing of November 18th. We have the VHI Strategic Plan Update and 2025 Connectivity Criteria. And before we turn to that, I move to approve the Care Board meeting minutes from November 13th, 2024.
Second.
All those in favor of approval, say aye.
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 Aye. And the minutes are approved. I will turn it to Stephen Andrews, our Director of Health Systems Data and Analytics, for the VHI Strategic Plan Update. And with him is Will Dempsey, the Director of Data Analytics from the Agency of Human Services, and Christina Choquette, the Director of Operations from Vital. Mr. Andrews?
Thank you, Chair Foster. As Chair Foster indicated, we're here to review the latest document from the VHI and from Vital. I'll go over the plan for the day. We're going to start by talking about why we're doing this review process. Then we'll step to how we're going through the process. Then I'll move on to the criteria for what we're trying to do today in terms of what VHI and Vital are supposed to achieve and how we review what they've achieved, and then go to last steps. So the GMCB oversight of HIE and the purpose of HIE are outlined in these two acts from the state of Vermont. 18 VSA 9351 indicates that the HIE shall create a strategic plan that will be revised annually and updated comprehensively every 5 years. They will talk about the integrated electronic health information infrastructure that they're building, and they will include standards and protocol designed to promote patient education, privacy, and physician best practices. 18 VSA 9375 charges the board with reviewing and approving the statewide HIT plan to ensure that the necessary infrastructure is in place so that the state can achieve the principles outlined in section 9371 of this title, which I will discuss in a little bit. The purpose of reviewing and approving the connectivity criteria comes from 18 VSA 9352, where Vital must establish criteria for creating and or maintaining connectivity to the state's health information exchange network. and they have to provide those criteria to the board every year. The process we're going through: on November 1st, AHS and Vital submitted the HIE plan and connectivity criteria to the board. We opened the public comment period right after that, and it's running through December 4th. Today, we are talking about the plan. The two groups will actually present their plans. And then on December 4th, right now, tentative, the staff recommendation to the board will be made, and the board will potentially vote on whether to approve or not. So for the HIE plan review, we're going to be asking.
Stephen,
oh,
sorry, this
yes?
is Susan. I'm not seeing your slides advance on my end. I don't know if others are missing that too.
Weird.
We're still on the first slide.
Yes, this is same for me.
Thank you for that. I'll try and figure that out. My apologies.
No worries.
Are you seeing them move now?
Yes.
Okay. So the HIE plan review, does anybody need me to back up and review material I already covered?
I'm okay,
Okay, so-
Stephen.
Thank you. For the HIE plan review, we're asking, is the HIE plan consistent with the HIT plan requirements of VSA 9351? Is it consistent with the principles for healthcare reform in VSA 9371? Is it consistent with other relevant legislation? And does the HIE plan incorporate national best practices and expertise, as well as feedback from Vermonters? I'm listing the requirements from 9351 here for completeness. I'm not going to read all the verbiage on the screen, but I will highlight the HIE is supposed to, the strategic plan for the HIE is supposed to support statewide use of electronic health information across the entire healthcare ecosystem. They are supposed to educate the general public and healthcare professionals about the value of digitizing health information. They need to ensure that they are using national standards for the development of an interoperable system so that data can flow fairly easily. They need to propose strategic investments in equipment and other infrastructure elements to support the work that they're doing. They need to recommend funding mechanisms to support this work. They need to incorporate existing healthcare information technology initiatives throughout the state and integrate with various technology components such as the Blueprint for Health, the Master Patient Index, other Medicaid management information systems. And finally, they need to address issues relevant to data ownership, governance, and confidentiality and security. There's 14 principles listed in 18 VSA 9371 that the board will use to weigh the merits of the proposed strategic plan. Again, I'm not going to read all of the verbiage, but I'll outline what the elements are. We want to achieve universal access to and coverage for high quality medical care. We want overall healthcare costs to be contained. We want to make sure that healthcare system is transparent, efficient, and accountable. We want to preserve primary care throughout the state, especially at the local level. We want to maintain that patients have provider choice. We want to achieve cost transparency. We want individuals to retain ownership over their own health. We want to emphasize the primacy of the relationship between patients and their own providers. And we want to continuously strive for improvement. We want cost containment and reduction of unnecessary expenditures. We want financing that must be sufficient, fair, predictable, transparent, sustainable, and shared equitability. We need to consider the impacts of any pavement reform tax reform plans. We need to ensure there's a partnership between consumers, employers, healthcare professionals, hospitals, and the state and federal government. And the state is responsible for ensuring compliance. For the connectivity criteria, the board will be looking at what the connectivity criteria are proposed to do and what they're supposed to achieve. They're supposed to be in alignment with the HIE plan goals, and they have to support the implementation of the HIE plan and achievement of the state's healthcare and health reform goals. So we're asking the proposed connectivity criteria is sufficiently clear to be operationalized by VITAL, the state of Vermont, and healthcare provider organizations. Looking ahead, there is a special public comment period open through December 4th. And on December 4th, we're expecting to have the final staff recommendations to the board on approving the HIE plan and connectivity criteria, and there'll be possible votes at that board meeting. Thank you, Chair Foster. Back to you.
Thank you very much. Is there any board member questions or comments for Mr. Andrews? Great. Mr. Dempsey?
Good morning, everyone. Thank you very much, Chair Foster, and thank you, Mr. Andrews. Appreciate the introduction and context to level set what we're doing here today. So it's a pleasure to be here, everyone. My name's Will Dempsey. I'm the Director of Data Analytics for the Agency of Human Services Central Office. And it's my pleasure to be here to present you all a few slides to just update you on what we've been doing in the last year and have some time for you all to provide feedback and have some conversations related to the proposed HIE plan. So Alice, who's a project manager on our team, is kindly driving the slides. So I will just let Alice know when we need to move forward. I just want to check, did everyone's slide go to the agenda from the cover sheet? Okay, cool.
Yes.
Thank you very much. With Teams, you never quite know. So our agenda for this morning from the HIE team's perspective, before I then hand it over to VITAL, Christina specifically, to do her section, is we're going to talk about the goals of the Health Information Exchange. We're going to have an overview of our steering committee, because the HIE is required to have a steering committee. And I'll talk about who those folks are and why we include various organizations. Then we'll get into the components of the Health Information Exchange. This is more on the technical side, what the system and its various components include. In the ecosystem of the Unified Health Data Space, which I believe many of the Green Mountain Care Board members should be very familiar with. This is a diagram that you all have seen many times before, but I'll give a quick update on where we're at and what's happening. We'll talk about our 2024 accomplishments, and then we'll wrap up with time for you all to have conversations about the strategic plan. Before I dive in, does anyone have any preliminary questions, comments, concerns? Okay, Alice, let's get rolling. Thank you very much, Alice. So these are the 4 goals of the Health Information Exchange. They should be pretty familiar to you all. These are kind of our static guiding light on the HIE side in the Agency of Human Services. So our focus is on creating one health record for every person, having better health outcomes, improving healthcare operations, and using data to enable investment and policy decisions. These are front and center in the executive summary of the HIE plan, and I believe have been for as long as the HIE plan has been published. Alice, we can go to the next slide. So our 2024 HIE Steering Committee, the stars next to folks' names signify that they are new in the last year. So many of the folks have been members year over year, but we also welcomed Jody Fry from OneCare, Andrea Delabrie, the Deputy Secretary for the Agency of Digital Services, Ken Gringas, who is the HIE, I think, Director of HIE for Vermont Care Partners, Song Nguyen, who is the director of the Department of Health's Office of Health Equity. And of course, Green Mountain Care Board's own Stephen Andrews, who is the GMCB representative on the HIE steering committee. So I want to just emphasize this is both a few internal state folks, including like we bring our privacy expert who's an attorney. We have Andrea, Deputy Secretary Delabrie, who's on the technical side. We have some folks from the Department of Health, but the vast majority of our steering committee are external partners, and we work very hard to engage with them and include them in the process, so that way we can meet their needs in the outside of the Agency of Human Services with HIE. Alice, we can go to the next slide. So the HIE ecosystem, this should be a fairly familiar diagram to folks as well. This is originally from the Office of the National Coordinator for Health Information Technology. They recently changed their name to something that's about a paragraph long, so I'll spare folks from reciting the full new name. But it breaks it down into this triangle, which is end user services, exchange services, and foundational services are grouped within the technology core of the triangle, and it's surrounded by policy and process, governance, and financing. And this, again, is one of our guiding lights in the HIE program for the decisions that we make, the priorities that we have, and the work that we do year over year. Alice, we can go to the next one. So I wanted to just touch on the what behind the Unified Health Data Space, commonly referred to as UHDS. And just to be clear, the Vermont Health Information Exchange that VITAL operates is a component of this larger concept of the Unified Health Data Space. And it's a collaborative initiative where our goal is to streamline data services. So collecting as much data as we can to make it available at the point of care, as well as for reporting, entirely based upon role-based access control. So what is appropriate for which user to have access to based on their role, and in nothing more. We have cost and usage, which is shared cost and usage among participants. And right now we are certified with our Health Information Exchange by the Centers for Medicare and Medicaid Services. So we do have a cost allocation that helps to fund the vast majority of the work that we do. And a portion of that is a state share, which is funded by the Health Information Technology Fund, which uses part of the claims tax. The UHDS plays a lot of different roles and has a lot of different points of interaction within the Agency of Human Services, as well as the broader healthcare community. And we have a variety of stakeholders, and you'll see that in our steering committee as well. We actively engage with the provider community and utilize VITAL's connections to the provider community to engage with them. We have an emphasis on quality, which again, that's OneCare. We have Blue Cross Blue Shield as well as on our steering committee. And we have our policy evaluation and regulation. So we have representatives from the Blueprint that come and bring expertise, as well as the healthcare reform team. And then we also have Stephen from the Green Mountain Care Board team, who's there to help guide us based on the Green Mountain Care Board's policies and regulations. My personal opinions, patients are the most important. And so that checks the personal health responsibility requirement that's in our legislation, as well as the population health line item, which is more about health equity and public health and how we can support those concepts and the work that both is being done by the healthcare reform team as well as the Department of Health. And then the last big bullet is that the UHDS will provide authorized access to folks who need the information in the healthcare arena. So we're talking about clinical data. That's pretty self-evident when we talk about VITAL and the work that they do with the Vermont Health Information Exchange. We're also talking about social determinants of health, more recently called social drivers of health. That language is still emerging. We have mental health and substance use disorder, 42 CFR Part 2 data, and then other data. We have other data that we're looking at in different formats, and it's based on what the need is, what the usefulness is, how we can establish data governance for it, and ensure that it's meeting the requirements that we have from a state and federal use policy. Alice, I think we can go to the next one. So here's the diagram that I talked a little bit about at the beginning. This is our unified health data space overview. We have on the left inputs, we have in the middle infrastructure, and on the right data access and analytics. So this is actually color coded by status, essentially. So the dark green is infrastructure that's currently in place and active. The slightly lighter green is in progress. The darker blue is in the 2025 HIE plan that we are presenting to you all, and it's included within that plan. And then the slightly lighter blue is work that needs to be done in the future. So that's 2026 or possibly even out further than 2026, depending on those priorities and the needs that are identified by the stakeholder community through our HIE steering committee. Layered both above and below that, you'll see data governance, security, patient education, and consent. And those are always baked into the work that we're doing and at top of mind for the health information exchange. Alice, I think we can get to the next slide. So these are our key accomplishments. You'll see a fair amount of green, a little bit of yellow, and one red. So I'll touch on kind of the high level, bigger buckets, which are bulleted on the right. So funding, we continue to have funding that's stable and sustainable through our cost allocation with CMS. For data governance, based on actually recommendations from the Green Mountain Care Board, I believe it was last year, we made our HIE Data Governance Council meetings public. So those are posted with the Department of Libraries, as well as on our website, and they're able to have the general public attend either in person, which we do have an in-person option, as well as virtually, based on what access is best for them. For technology, a couple of very exciting pieces that we've been working on the last year are expanding bidirectional exchange of the immunization data, and that's in partnership with VITAL as well as the Department of Health. And that work has gone in a really positive direction, and we're very excited with the outcomes that we're seeing there, as well as expanding electronic lab reporting, ELR interfaces, beyond just COVID response ELR interfaces to include other labs, so that way patients and providers are able to have as much information within the Vermont Health Information Exchange as possible. Then we have the policy and process bucket. So VITAL did an electronic patient health data education campaign. Many of you will probably remember social media and or radio ads. I certainly remember the radio ads living in Lamoille County. We also had a continued incentive program to connect providers to the VHI, and this is called MDAP, which is the Medicaid Data Access and Aggregation Program. This incentive program is designed to fill in the gaps that HITECH left behind, where only certain qualifying providers were able to utilize HITECH funding. MDAP has a broader set of requirements to include folks that work in the mental health as well as substance use disorder fields to be able to collaborate and have them utilize those funds to bring in electronic health records as well as connect to the health information exchange. Then we also completed development of the Vermont Department of Health VHI integration strategy. We worked with the Department of Health to have a consultant look through all of the Department of Health systems, computer systems, map them to the VHI as well as what would be useful or not, and then prioritize them with input from various stakeholders. So the first two data sets within that plan are incorporated in the HIE plan that we submitted on November 1st. That's birth data, because VITAL already gets death data currently, which is fantastic. So we're going to be rounding out the VITAL record side of things with birth data, as well as bulk upload and manual entry of immunization data. Right now, VITAL gets, I think it's in the high 80s to low 90s of HL7 messages for immunization data. This will help to continue to increase those percentages because some providers only issue a handful of vaccines on any given week or month. So they do a manual entry one by one, or they upload an Excel spreadsheet into a a portal that the health department has. Right now, though, that data doesn't hit the VHI because it goes directly into the immunization registry. So we're working to fill that and pull that data into Vital's VHI as well. And then last, but certainly not least, because this was a significant lift on the state's part, as well as Vital and the designated agencies, is all of the designated agencies in Vermont are now contributing production data to Vital. I'm going to emphasize to Vital and not the VHI. It's going into a separate repository based on 42 CFR Part 2 and SAMHSA requirements, but the data is with Vital and is being reported. And we have really appreciated the partnership with Vermont Care Partners and their participating organizations, as well as Vital, to get that work across the finish line. So those are the highlights. I'm going to just pause here for a moment because I've been talking a lot and see, does anyone have any questions based on this specific slide? Okay, hearing none, we can continue on, Alice. Thank you very much. So this is, as Stephen talked about, this is our 1-year strategy refresh. I believe our next 5-year refresh is in 2027. So I wanted to just kind of outline what inputs went into this refresh that we did this year. And that's strategic planning from the HIE steering committee. We always incorporate them to include their diverse viewpoints and kind of boots on the ground knowledge of what's happening in Vermont and what the needs are within the healthcare community. We also incorporate the Federal Health Information Technology Plan to ensure alignment with that. This year, we incorporated Act 167 and its resulting report and what we could respond to and incorporate from that resulting report in the HIE space. Potential participation in the AHEAD model, which is the All-Payer Health Equity Approaches and Development model with CMS. And then last but certainly not least, what we've completed and achieved in the past calendar year. So Alice, I think we can go to slide 10. So on the left here, you'll see our strategic goals, as well as along the top, you'll see how it's hitting those various high-level HIE goals, as well as some more specific goals that we have within the Agency of Human Services and the HIE itself. I'm not going to read all of this at you. It's in the HIE plan as well, but it's to outline how we're meeting these various goals around data completeness and quality and standardization, patient education, provider outreach, care coordination, social drivers of health, technical assistance for rural providers, and ongoing technology enhancements as a few examples, and how those fit within all of the various other high-level goals that the Health Information Exchange program has. Alice, I think we can go to the next slide. And if I'm not mistaken, I believe this is our last slide, everybody. And I know this is a lot of data, but we do try to incorporate this more for informational purposes than anything else. So that way the Green Mountain Care Board is aware. We do keep month-over-month KPIs and metrics with Vital. They report them to us. We do use some of these in our outcomes-based certification, which helps maintain the funding through CMS for the Health Information Exchange. So we keep track of a wide variety of data elements, the number of user accounts, organizations, potential organizations, patient queries, lab results, RAD results, trans results, VXUs. What I would kind of highlight for you all is the master patient index and the matching percentages that we're hitting with the MPI, which is between 98 and high 99%, which is fantastic. We're very, very happy with that, as well as the percentage of total immunization messages received by the immunization registry from the VHI. So you'll see it's in the high 80s, and then in September, you'll see a little bit of an uptick into the low 90s. And our goal with that work that Vital and VDH are doing is to get that as high as we possibly can. And then the bottom one is that the blueprint extract that they use for their reporting every year is delivered, and that it was delivered. So Alice, I believe that's the last slide. I think we can go back to seeing everyone. And at this point, I believe it kind of switches over to, do folks from the Green Mountain Care Board have feedback, and what sort of format you all would like to do that in, if there's a specific order.
Thanks, Will. We're a little informal sometimes, so I think today we'll just open up to any board member questions if there are any. People may want to hear from Vital first, but we can open it up if anyone does have any questions or comments for Will at this time.
Absolutely. Thank you all.
Right. And hearing none, we can move on to Ms. Chiquette if you're ready.
Sure thing. Let me share my slides. Let me just do a check-in and make sure that everyone can see my slides.
Yes.
Great. Thank you. Hello, Christina Choquette. I'm the Director of Operations at Vital, and I'm very pleased to be back once again to talk about the VHI connectivity criteria and the proposed criteria for 2025. So I'll do a little bit of a reminder for those of you who don't live and breathe with VHI connectivity criteria. It establishes the criteria for healthcare organizations to connect to the VHI so that there are no surprises, and we're using standards that one would expect in order to exchange data. What's important for this year for the proposal is that the criteria tiers remain unchanged, and I'll get into that a little bit further. And we kept them the same to align with the United States Core Data for Interoperability, or known as USCDI. And as a reminder, those are data that they're standards actually that are published by, now I'll give you that long name that Will was talking about before. It's published by the Assistant Secretary for Technology Policy, the Office of the National Coordinator for Health IT, formerly known as ONC in the past, and now it's just a little bit longer of a name. And the USCDI specify common data classes, data elements, and terminologies to support interoperability. And you may recall last year I presented a list of them. Think of patient as a data class, address as a data element. When you move into data elements such as race, ethnicity, there are terminologies that are published so that you're exchanging standard terminologies on those data elements. Why do we align with USCDI? Because it advances interoperability. And this slide might look familiar from last year. Want to review that again with all of you. The USCDI uses that common set of data so that, again, there is consistency and no surprises in exchanging data. And it's useful for patient access, moving down that path of bringing the patient into the world and having them have access to their data. The Health IT certification program requires EHRs to be able to exchange USCDI data elements. Last year, I talked about how version 1 was the current standard. It still is, but it expires on December 31st, 2025. Version 3, which expands upon that foundational work, actually becomes the new standard beginning January 1st, 2026. Last year, what had been published is sometime in 2025. They were planning on using version 3, but they've actually landed on the date of January 1st, 2026. USCDI is required for document-based exchange and for APIs as we start to move down that pathway of using standard application programming interfaces to exchange data, especially with patient APIs, so that patients have access to their data, as well as within the healthcare information exchange community, between EHRs and other stakeholders, this will become increasingly important, which is why the last point is federal programs and clinical practice guidelines reference the ability to capture and exchange US CDI. If it's a standard and everybody's using it and everybody knows what those data and classes and data elements mean, the more prolific the health information exchange will be. And lastly, this slide might look familiar to you. We've been presenting this each year about the maturity model and that journey along the connectivity criteria. The only thing new that I've added to this is the fact that the US CDI version 1 is going to expire on December 31st, 2025, and that the new one starts January 1st, 2026. So I'll stop here and see if anyone has any feedback or questions.
None from me. Any other board members?
Great. Thank you.
I believe Mr. Andrews, is there anything further from you, or should we take comment from the healthcare advocate and then the public?
Nothing further from me.
Great. Any comments from the healthcare advocate?
Only that we fully support the approval of the HIE strategic plan and the connectivity criteria. Thank you.
Thank you, Mr. Schulteis. And any public comment via raise the hand? Okay, hearing none, any new or old business for the board? Mr. Dempsey, Ms. Chiquette, and Mr. Andrews, thank you very much for your presentation today. We appreciated it. And I will move to adjourn.
Second.
All in favor, say aye.
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 Aye. And we're adjourned. Everyone have a nice day. Thank you.
Thank you.
Everybody.
Bye now.